there was a question that came up about OB complications. So for everybody, if you're taking the EMT, advanced EMT, especially for advanced providers at the AEMT level, you get a lot of OB questions. But for everybody, let's talk about the most important things you need to know when it comes to OB topics. Everybody good so far? Give me a thumbs up if we're good, or let me know if you have a question. Give me a hands up if you have a question. Thumbs up if we're good, hands up if you have a question. Brendan, what you got? Good or question?
No, I'm good.
You good? Are you learning, my man?
Yeah, trying to.
You trying to? Hey, well, what's happening? Do I need to repeat something? Do I need to go over something?
No, I'm good. I'm learning. I
Okay,
feel it's a
don't
lot of
fool me
stuff,
now.
but it's just refreshing.
Okay,
Yeah,
refreshing in a good thing, in a good way.
yeah, in a good way.
Okay,
Yeah,
I mean, I think that's
yeah.
the only refreshing.
Just trying to pass this paramedic.
Say it again.
I was just trying to get to pass this the NRENT, the paramedic.
Yeah, but you don't want to just pass, my man. You want to pass and be great. Okay.
Right.
Yes, I know you want to
Yep.
pass, but I need you to pass and be good when you pass. Well, in fact, be great
Right.
when you pass. Okay. So
Right.
let's go over. So, Brennan, you're going to hang in here with me. Let's talk about some of these OB complications. Okay. You ready? Here, let's just pop you in so I can see you. All right. Let me find you again. All right. I need you to jump in the car with me. You ready for a ride? All right, let's go.
Yeah.
Let's talk about OB complications. So the biggest OB complications, this was somebody's question. I don't remember who asked me, but somebody asked this question. The biggest things you want to know is a lot of these OB complications, we can kind of quickly figure them out. All right, how do we figure out that it's probably an OB related question? They tell you about a female within childbearing age. Okay, what's
Right.
childbearing age? Well, that starts at the onset of puberty to menopause. Okay. Now, when does menopause start? We say that menopause on average starts by age 51 years or 50 and a half years. Okay. Puberty depends on the girl. What is the age by which menses should start? When should the female get her first period? Okay, it's going to vary for everybody. But when we get concerned is when the female has not had a period by age 15. Okay, if no period, no menses by age 15, now we're actually concerned. There could be primary or secondary amenorrhea that needs to be investigated. But 15 is the number you want to know. That's when it becomes concerning. So let's say you have a daughter or something and she hasn't had her period by 13, nothing to freak out about. Maybe hers will just come a little later. By 15, though, we're definitely concerned because the hormones should have surged by that point. It should have happened. All right, now, when it comes to a big complication is going to be vaginal bleeding when it comes to OB stuff. The way you want to think about this is time based on time, okay? So, of course, pregnancy is divided up into 3 trimesters, right? Each trimester is approximately 13 weeks. So the first trimester is from the time of pregnancy up to week 13. Starting week 14 to week 26, that's the second trimester. Week 27 to week 39 is going to be the third trimester. At what point is mom considered full term? Different books will say different things. Some say 36, some say 37, somewhere around there. Why do we want the baby to stay in the oven and cook as long as possible? Because at around week 34, some books will say 32, other books will say 34, but somewhere around there, this is the part where surfactant starts being made. Surfactant is that kind of smooth, detergent-like substance that opens up the alveoli to reduce the surface tension so that you get more gas exchange. But it doesn't even get made until the baby is about 32 to 34 weeks gestation. That's why we don't want the babies being born premature, is because their lungs are not fully developed. They don't have enough surfactant yet. So we need the baby to stay in as long as possible, but we don't want the baby staying in 41, 42, 43 weeks, because now we can actually have other types of complications. Okay, if we have vaginal bleeding that happens in the first trimester, the top 2 things I want you to know are a miscarriage. So that's going to be what's called a spontaneous abortion. Now, I know I use the term abortion. This has nothing to do with your personal beliefs or your judgment. That's just the medical term for a pregnancy that ends under 20 weeks. It's called an abortion. Whether somebody goes to an abortion clinic or just happen, like if they go to an abortion clinic to do it or they do it through some back alleyway, that's called an elective abortion. Or even if they do it at their doctor. Or if it just happened on its own due to the body, then that's called a miscarriage. But both of those are under 20 weeks. Okay. And there again, it's not for you to pass your judgment one way or the other. It's just the word. It's just what the word means. Okay. Now, if they have vaginal bleeding in either the second or third trimester, so after a week 13 or definitely after week 20, then it's probably likely to be some kind of placental problem. The main problems, and these are not all the problems with the placenta, these are the ones that you need to know at your level. The two main ones are going to be placenta previa and placenta abruption. You could also have placenta increta, percreta, accreta. For you just need to know placenta previa, placenta abruption. Okay? Brendan, what is placenta previa? What's placenta previa?
When it delivers like too early.
Right. Okay, so here's placenta previa. So let's draw in a uterus. We've got ovaries. All right, we'll put in a vaginal canal. So placenta previa is where, so I have that in brown. Hold on. Placenta previa is where we get a preview of the placenta at the cervical neck. Okay. So as we go into the vaginal canal, there's the placenta there. So the placenta should be attached to the uterine wall. But instead, the placenta moved, and now we get a preview of it down low. That's placenta previa. In fact, I need to put that one in red. Placenta previa. Now, don't worry too much about the color. Don't worry about the whole bright red, dark red stuff. What you want to worry about is pain versus no pain. So placenta previa, is that going to be so that it's described as bright red and painless? All right, so good job, Brian. On the other hand, placenta abruption is where the placenta was supposed to be attached to the uterine wall, but it just abruptly tears, and now it's no longer attached. Okay, so an abruption, it's typically described as dark and painful. What I want you to know is the either pain or no pain part. Forget the color, because as that blood just sits, the color will change. So even if it started as bright red blood, it'll end up as dark red blood eventually. But what I want you to know is painful versus painless. So if they describe somebody with vaginal bleeding in the second or third trimester, you need to think placental problem. If it's painful, that's probably an abruption. If it's painless, it's probably placenta previa. Okay? Another thing that happens with OB, you want to know hypertensive emergencies in OB. Give me a thumbs up if you're still with me, everybody. Okay, let's talk about hypertensive emergencies in pregnancy. You still good, Brendan, right?
Yeah, good.
Okay, here, I'll take you out of the box for a minute. So hypertensive emergencies in pregnancy, okay? We call it different things based on different time periods. If mom already had high blood pressure, she was already taking blood pressure meds, or maybe it wasn't diagnosed. But if she already had, if it wasn't diagnosed, she doesn't know it probably. But if she had hypertension before she got pregnant, it's just called hypertension. She's just hypertensive. But if today she gets pregnant and then she develops hypertension later, that's called gestational hypertension. Like if she's a diabetic after she gets pregnant, that's called gestational diabetes. If she has high blood pressure after she gets pregnant, that's gestational hypertension. That means it was brought on by the pregnancy. But that also should mean that once she's no longer pregnant, she should no longer have high blood pressure. Sometimes that doesn't happen though. Okay, so gestational hypertension typically, so it's after she gets pregnant. Now, but gestational hypertension can happen anywhere through any term of the pregnancy, first, second, or third trimester of the pregnancy. It can happen the whole time. The things that we are most suspicious for after 20 weeks is either preeclampsia or eclampsia. What's the difference? In preeclampsia, this is where you have hypertension in pregnancy, primarily after 20 weeks. Now, what are some symptoms or some signs? It can be things like pain, abdominal pain, nausea, blurred vision, headaches, things like that. Now, so if she has hypertension that's causing all these other problems, that's called preeclampsia once it's after 20 weeks. But if she has hypertension that's causing all these symptoms or signs plus seizures, then it's called eclampsia. So eclampsia is hypertension plus seizures. Paramedics, what's our drug of choice for eclampsia? Nice.
Mag.
It's going to be mag sulfate. Okay. Now, mag, give me 3 situations that we use mag for. Let me give you a hint.
God, just say it.
So these are our set. These are so ready, set eclampsia. So we're going to have S is seizures. No. I'm sorry. That's no, that's not S. S is status asthmaticus. Status asthmaticus. That's where they have a prolonged asthma attack. The E is eclampsia. So that's going to be hypertension plus seizures. And then the T is going to be torsades. I mean, Billy is just showing out for real tonight. Nice. Okay. So some other complications that we worry about with OB patients are supine hypotensive syndrome. All right. Eve, what's your testing level?
Paramedic.
Nice. Perfect. So let's bring you in, Eve. I know you were just sitting there like, please, coach, call on me. Okay. I heard you. I got you. All right. So Eve, supine hypotensive syndrome, what is it?
Is when she lays down and the baby, the pregnancy puts a lot of pressure on
Okay,
the...
so here's mom with his big belly. She lays flat on her back, and then there's his baby inside, right? So baby's just out here swimming, just hanging, having a good time. But what is the baby pressing on? So the baby starts pressing on this inferior vena cava. And what's the job of the inferior vena cava?
I'm on a blank right now. Sorry.
That's okay. So the inferior vena cava is how blood comes. So let's do it this way. Let's take our heart here. And remember, blood comes into the, when blood first comes into the heart, the very first place that it has to go is the right atrium. The 3 ways that it gets there is one of them is here. That's the inferior vena cava. The other way is from the top. That's the superior vena cava. And then within the heart, it's called the coronary sinus. So we have an SVC, superior vena cava. We have an IVC, inferior vena cava. And then we also have a coronary sinus. That's just the venous drainage. That's the vein side. You have an arterial side and a vein side. That's the venous drainage inside the heart. But so now we have, let's put this baby, when mom is on her back, the baby is pressing on the inferior vena cava. So let's put a big baby here pressing on this bad boy. And now that prevents blood from coming back up to the right side of the heart. So could that be a problem if mom does not get blood to her heart? Eve?
I'm sorry, they're talking on the radio and I can't hear.
Tell them to shut up. We're busy right now. Okay. Okay. So if if this baby is pressing on this inferior vena cava, it's going to prevent blood from coming back to the right side of the heart. And if blood doesn't get to the right side, it doesn't get to the left side. And if blood doesn't
Left
get to
side.
the left side, it doesn't go to the body.
Mhm.
So if blood doesn't come into mom's heart, is that a problem?
Yes.
Yeah, because if blood doesn't come into mom's heart, it also doesn't get to baby. Make sense? Because
Yes.
it has to come to mom's heart so it can eventually pump back to the baby. Okay,
Mhm.
so supine hypotensive syndrome is where mom is laying on her back, and so she's supine, and it causes hypotension. So it significantly drops her blood pressure because you knock out the inferior vena cava, you prevent blood from coming to the heart, so you prevent blood from coming here. And when blood cannot come in the left ventricle, blood can't leave out of the left ventricle, and that's where it gets measured as blood pressure once it goes into the aorta. So if blood never makes it into this aorta, the body says, "Woo, I don't have any blood in here." And the machine registers as no blood pressure or low blood pressure. Okay?
Okay.
The blood is still in her body, but it's in the wrong place in her body. Okay? It's like stuck down in the legs and the feet. Okay? So that's supine hypotensive syndrome. So what are we going to do about this, Eve? How are we going
to put her in a position of comfort left?
Okay, so we're going to put her in on her left side. So that's going to be called the left lateral recumbent or left lateral decubitus position. Okay, both of those mean the same thing. But all we're trying to do is we're trying to get this baby off of the inferior vena cava. What if mom's in cardiac arrest and we got to do CPR on mom? What do we do it? How is CPR different when she's pregnant?
Well, we can't do the.
Say it's the same.
See, that's a question that I got the first time I tested. And I actually believe it wrong.
Just say
it's the same, but I got it wrong.
You got it wrong?
Yeah.
Okay, so CPR, like mom's heart is still in the same place, whether she's pregnant or not. Like it's not like her heart moved down here somewhere. Her heart is still where it is. We still do chest compressions the exact same way. We just add one more step to it. And so CPR is essentially the same. Pregnant or not, she still has a heart. So it's just like anybody else with a heart. The only difference is we may have to kind of take our hand and like this big uterus, we may have to displace it to the left side just to get the baby off the inferior vena cava. Does that make sense?
Yeah.
But the CPR itself is still the same as anybody else that you do CPR on. You do it the exact same way, the exact same hand placement. It's just you have somebody else take their hands and push the baby over to the left side to get this baby off of this inferior vena cava. So we're going to move the baby over here. Does that make sense? Okay. All right. So that was somebody's question.